I'll just go in.
Okay. But she said we don't have to wait for her, especially if she gets tied up. So downstairs.
Oh, Kristen, I thought I had a note.
Can you guys hear us?
Yep.
Okay.
Kristen, I thought I had a notepad in the front of my bag, but I must have taken it out full to replace and haven't. Is there a place I could grab a notepad?
Hey,
Or
are you okay?
a couple of pieces of printer paper even?
Yeah.
Could you grab it for me? Thank you so much.
The what one, honey? I don't know. You have to. Oh, I think there was only one of those. Sorry, bud. Yeah. Okay. Try to take it easy. Okay.
Strategic Caring Solutions, this is Erin. How can I help you?
Hey, Erin, this is Phil. How are you?
Hi, I'm good. How are you?
I'm about to start chairing a meeting, so I have to jump unless you need something.
Let's see here. Sorry about being slow to
Okay.
get
I
Opportunity.
appreciate you so much. Thank you.
Andrea's got the creepy crud. Andrea, she's got, she woke up with a fever. And my older son has been under the weather all weekend. God, I'm looking for his favorite tea. Oh. Which we're having.
How old are they?
My kids are 22, 20, and 18. So 18 and 20 are still at home along with one of their buddies because bonus kids. So it's like they know enough of what to do when they're under the weather, but then it's like, where's my tea?
Yeah, especially if you make it for them a certain way.
Well, I put Matt's dad's honey in it.
Oh,
Yeah. Yeah, and then I actually made bread yesterday that called for a third of a cup of honey, and I used Matt's dad's honey.
how was the bread? I
Amazing.
was gonna say it's probably
It was exquisite. It had a weird shape. I think the dough ended up being extra wet, so like the top kind of mushroomed a little bit instead of like rising up.
Yeah.
It was delicious. So it was a little unsightly. No Paul Hollywood handshake for me.
mushroom bread. It's a new one.
Yeah.
Add that with our coffee.
But it tasted good. So yeah, I texted Matt this morning. He's right. Yep. Well, and also his kids like my son's band, and they just got a gig. Yeah, he's in a great band. They actually dropped a single in December. You can ask your smart speaker to play it, which is kind of cool.
You could say Hey Sonos by Blanket Blank.
But yeah, they just they opened for a Seacoast band in Boston 2 weeks ago, and that band was really excited by how many people came out. So they offered them a spot to open the Stone Church in 2 weeks.
Where's the Stone Church?
Oh, Teresa.
I'm sorry.
It's in Newmarket. It's a historic
Okay.
rock club. It's on the Registry of Historic Places. Really? Yeah. I mean, I'll tell you, but that's partly how I moved to. But being able to play there, like his dad's a professional musician. My kid could gigs there. What's the name of it? Rosewood Park. Yep. Their single is called Melody. They have other singles that will drop.
Your son is a vocalist.
He's primarily lead guitar and backup vocals. There's one song that he sings lead. It's your basic 4-piece. There's another guitar player, lead vocalist, bass player, and drummer. The bass player cracks me up. He's got a little handlebar mustache. And unless it's like 5 below, he doesn't wear a shirt, like ever.
Oh, so he's a shirtless musician.
Most of the time. Yeah. Yeah. Yeah, when they played in Boston, my husband was like, oh, look, Tommy took his shirt off. I mean, to be fair, it was more.
A real problem at 12 degrees.
Yeah. Yeah.
So they probably have late nights. and Sleep. Right? Musicians schedule.
Son used to it. The last few months. The brain violation has happened at warp speed. So it's actually got it. Sleep schedule and.
Morning. Morning.
Hi, Henry.
How are you?
Good. How are you doing? Sorry, I was trapped in a thought. I just needed to capture. Get it out. I did hear from Kelly a little bit ago. She is minutes behind.
Okay.
But she didn't want us to wait for her, so I don't know who else you might be expecting.
You see the, David should be here.
Okay.
Sorry.
Okay. See you though.
What? And you saw that Carolyn Virtue.
I did see that.
That's great.
Yep. Yep.
And, so in terms of meeting, Bob, you, Rob, and come in later. You have to get pulled into something else.
Okay. All right. Kristen, can you tell if we have a quorum?
Oh, I'm just about doing that.
Okay. Sorry to rush you.
No, I should have done that while was just sitting here.
How many do we need? This is when having Carolyn is helpful.
How many do you have?
Doors, Rob. Tommy, Steven.
What's the total number of membership right now?
Yeah, I'm about, yeah.
But it's like, what's the membership number? Like, do we have 13 people on the membership, not present at the meeting? I'm saying in general, that's how we can make sure we have a quorum.
She's
20.
using the attendance list to
Okay.
do the calculation.
Yeah, I'm quickly.
Hey, Kelly.
Hey, Kelly. Happy New Year. Super fun sweater. Thank you. I'm just trying to figure out.
C12.
And what is the total membership?
There's
How much?
22 seats filled.
So we have more than.
More than
Yeah.
half.
Yep. I think that constitutes
Okay. Hey, thanks for your patience, everybody. We just want to make sure we have a quorum, and it looks like we do, so thank you. We're gonna open the meeting. It's nice to see so many people on camera. Thank you. Okay, so welcome, everybody. Gonna jump right into the agenda. We have nothing on consent today, so check that right off the box. We do need to review and approve minutes. I think they went out. Kristen, when did they go out?
The same day as the agenda,
Okay.
which was Wednesday, maybe? Last week.
Has everybody had a
Last week.
chance to review the minutes?
Yep,
Does anybody want to make a motion?
I will. Kathy Bates.
Thank you, Kathy. Do we have a second?
Second.
Thank you, Kelly. Any discussion? All in favor?
Hi.
Aye.
Aye. Aye.
Sounds like the ayes have it.
Any objection?
Any objections? Abstentions? Hearing none. Motion
I'm
carries.
grabbing someone.
1/3 of the membership.
That's so low. Awesome. Okay, good. I will make a note. Okay. All right, so I'm gonna turn it over to Kelly to give us a little update on the Beneficiary Advisory Committee Subcommittee.
Really, Kelly and Dave, I think.
Okay. Oh, yeah, sorry.
It doesn't say that. Oh, do you want to jump in first?
Yeah, sure. So as we've talked about in previous meetings, there are the new CMS rules that require states to form a beneficiary advisory committee. We had sent out some materials and gone through some slides previously. So we got a list of folks that were interested in joining the BA subcommittee, and we're going to be setting up an initial meeting for later this month to talk through some of the planning and the objectives of that subcommittee to create beneficiary advisory committee bylaws that can get presented at the MAC and approved, and then recruitment to the BAC as well.
So our intent really is to begin to convene those folks who have expressed interest, sort of a last call here. If anybody else has any interest in participating, you're welcome to join. We'd love to have you. Please reach out and to Kristen and let her know.
So the requirement is that we start in July.
Yeah.
So doesn't seem like it's far away. Seems like it's far away, but it really isn't. It goes by very fast. And we've been, doing some research on what some other states have had. So we won't be starting with a blank sheet of paper to sort of work through this.
Yeah, with regard to establishing the bylaws, we have some other states that we have looked at that we can utilize. The cadence of this group, right, will change. MAC 1 month, BAC the next, MAC, BAC. But we really are looking for meaningful participation from beneficiaries. And so it's important that we get this group meeting now, get all of the elements in place so that we can develop the membership for the BAC.
Just one clarification, BAC has to come before MAC.
Yeah.
And it's 25% that can be on both, right?
Yes.
Yeah. The MAC needs to be made up of 25% of BAC, Beneficiary Advisory Committee members.
Kathy?
I'm slightly confused as always. So the BAC that is 25% of people that receive services. Is that what you mean by beneficiaries?
It's beneficiary, direct beneficiaries or family members of beneficiaries. It's intended to get as close to the people receiving the services as we possibly can.
Okay, well, family members is different than actual people receiving services.
Yeah.
But
Kathy, think in the instance of a child, right? That child may not be able to.
yeah, that's true. Okay. So if do you have to be on this the MAs? You guys are throwing around initials and I'm getting confused. I heard MAC, BAC, and something else. So
Kathy, MAC is what today we have called.
yeah, I know.
MCAC, yep. So it's Medicaid Advisory Committee and Beneficiary Advisory Committee.
So
Yeah,
do
there's
you
not
have
a
to
third.
be on both? Do you,
No, it's not a requirement to be on both.
okay. I guess I get it.
You can be on both, but there's not a requirement to be.
Okay, and so, and is it gonna be every other month, or
Yes, every other
Right.
month is correct.
okay, I'm getting it. Alright, thank you.
And we'll come back and go through all of that again. When we are planning for this meeting, the word I
Yeah.
use is, let's continuously socialize that we're moving forward on this process. And so
Alright.
today, we're just sort of repeating that we're socializing. We're going to convene those folks who have volunteered to create the bylaws and help with the membership development of beneficiary advisory. And most importantly today is this call out, if anybody wants to participate in that process and they've not yet raised their hand, to let Kristen know that they want to participate.
Well, because I would be interested in being on the BAC, but not necessarily as part of this group also.
Yeah, okay, great.
You know,
That's great to know. She's interested in being on both, yeah?
no, I said not necessarily on this.
Oh, not, but
Okay.
BAC.
Right.
Thank you.
Don't
Looks like
give me
Melissa
too
has a
much.
question.
Don't give me too much work.
I'm
please.
volunteering you left and right now.
Yeah. I get
Melissa.
volunteered a lot. I'm voluntold.
Thank you, Kathy.
All right.
Melissa
thank
Burke, it
you.
looks like you have a question.
Yes, so I have already indicated that I was interested, and I've been on the email that had been sent out. I'm wondering if people who are not already members of MAC are able to join the recruiting committee. Just making sure that, I obviously represent the area agencies, individuals with developmental disabilities, brain injuries, and I want to make sure that they have their voice heard in developing the bylaws and, what recruitment is going to look like. Is that an opportunity for this group, for the subcommittee?
So I guess I'd address it in two ways. These meetings are public, right? So that as we bring the bylaws forward, and you want to share, our materials are posted online, so I think that that's a way to share that. And certainly through you, if they have individuals that they'd like to see on the BAC or MAC, that you can be a conduit for that.
And then there's a question that somebody who doesn't have a camera on, can somebody read it? I can't see it.
Gary?
Martina
Oh, hi, Lisa, sorry.
That's right, she's.
on, and I'm really sorry. I was late getting on. I had another thing going on. And it has my husband's name on here, so sorry
Yeah.
about I was having trouble with my Teams last time. I've been on MCAC as a consumer advocate since 2008, a long time. And I'm looking forward to this change, or what's they're trying to bring forth in having consumers be really part of the process. What I hope is that we get a large breadth of scope of individuals from, elderly in long-term care, people who are in the mental health system, of course, DD and brain injury, which I represent and Marissa does, and I'm not sure who else is on, and Kathy. So I'm guessing I'm going to repeat probably what Marissa. How do we recruit, and how do we find individuals to be part of this group? It is a lot. It's a huge learning curve too.
Well, everybody will be starting brand new, and there's not been a BAC previously, and so I think I think what we'll be doing is bringing forward as part of the work group some of the learnings that are out there nationally on this to help inform what the bylaws are. I think in terms of the recruitment part of it, it's really members of this committee who have, networks in which they can interact with to bring forward participation. There's no, if you will, formal process that we want to use per se. I think other than to engage as many people to bring forward good representatives of the beneficiary community who can, as you say, represent the widest group of who the Medicaid program serves. And some people can do more than one area too.
Okay. That sounds great in theory, but sometimes, I mean, and like I said, I've been on since 2008. I worry, and the devil's advocate here. So our systems have individuals that we serve. Sometimes the systems bring forth advocates that may fit the system. I don't know if I'm going to explain this correctly. We can't just we can't be in a box when it comes to selecting individuals to be on MCAC to really give us the scope of what's going on out there. And that's what I'm just concerned about. I just want to make sure that we have a large voice at the table, what's really going on out there, and how do we weed through who we're selecting. And that's just my concern. So thank you.
Lisa, I share your excitement. I'm really looking forward to it. I know that I've been socializing the idea, just, in the last month as we're getting ready to try to convene the group. But what concerns me is how do we keep them engaged? I think we're going to have, and that's going to play out through the relevance of their input, how we accept and adopt and adapt to their feedback. But I can tell you in my discussions here with the department, everybody is very, very excited about that opportunity.
Great. I am too. So fantastic. Thank you.
Okay. Thanks, everybody. So just want to hear from members and guests about requests for future agenda items. We try to solicit agenda items in the hopes of, making all of the content in the presentation meaningful for as large a group as possible. So are there any recommendations or suggestions or curiosities that we can add to future agendas? Anything coming through in the chat, Kristen?
Yes,
there was,
yeah,
it just
it disappeared too quick for me. Yeah.
Lisa, could we have an update on the EVV and how it is going? Problem?
So just for folks who maybe couldn't hear Kristen, that we have a request for an update on the electronic visit verification, or EVV, implementation.
We can have that.
Great. Any other ideas? That's a great one. All right, hearing none. You're always welcome to submit either directly to Kristen and Henry, or to Kelly or I, or whatever.
There was Joan Fitzgerald, Provider Relations Training and Advocacy.
Joan, can you be more specific by what you mean there? Yeah, you're on mute.
Yes, I was just thinking if you're wanting to have better and stronger providers be part of Medicaid, that we talk about what kinds of criteria that would include. Of course, I'm coming from the dental space, but there are other, many providers that serve the needs of the Medicaid population. So how do we provide them with the support that they need, the knowledge that they need?
So maybe a first round is to just say, this is what we do today, and then you can comment on that. This is what's available today. And
Sure.
we could do that as a step one kind of meeting.
There was another thing in the chat. Madeline Ulrich, thank you for asking. I would like to hear about the workforce direct support workers are going.
One more time.
She was asking, I would like to hear how the workforce direct support workers are going.
Maybe if she could come on.
Madeline?
You talking about DSP workforce development, maybe?
Yeah, I'm on. Hi. I had surgery, so I'm not showing my face, but
That's okay.
yeah, my foot's up in the air. So yeah, I just am. We had a lot of concern about direct support workers in my particular world and in working is around the CFI program, and we had such a shortage of workers, and I will say that I think I've seen an improvement in that we get emails on a somewhat regular basis from agencies like Accentria or some of the other agencies saying, oh, we have a worker that needs hours. We're seeing more of that. And I think that their pay they were given more money for pay increase. I just wasn't real clear if that money was a long-term thing or just a short-term ARPA thing. Just wanting, because at the crux of everything we do is those workers there in the home. I just want to make sure that we, are just kind of keeping an eye on that and making sure that they're continuing to, be reimbursed in a way that there isn't as big of a shortage. I mean, I think we still have a shortage, but I think it's better, or at least I feel like it's better. I don't know what the statistics are showing. So that's kind of where, what I'm kind of, or where I was kind of coming from. Thank
That's
you.
helpful. Thank you.
Great. Looks like Doris has a suggestion.
Yeah, the same managed care rules that allow for the development of a BAC also allow states to re-examine their Medicaid advisory committees. And I haven't heard any discussion about that. Is that something that's in the works or?
Yes. Yes, we earlier when we did the managed care rule update, we talked about MAC and BAC. The big change is obviously BAC. MAC we also will have to make changes on, but I think that's more of an extension of what we're doing as opposed to a full-born creation. But I think we wanted to get on the road of BAC. We'll be getting on the road of MAC as well.
Thank you.
We can at a future meeting get that down to.
Great. Anything else? Okay. Super. Rob, your timing is excellent.
I figure.
You're up.
Morning, everybody. So legislative session has officially kicked off. However, they still have not published a lot of the bills that I'm following. So I still have to speak in very general title terms. By next month, everything should be published and ready to be discussed more in depth. But I guess I'll go ahead without further ado.
I'll just introduce your.
Oh, yes, I'm sorry. And this is Claire Markey. She's a 3L with UNH Law. She'll be with us for the semester.
People who aren't in law.
Oh, well, I'm so used to so many lawyers. $3 the third year of law school. It's the last year, and she's in her last semester, so she's soon to be attorney, Markey. All right. Without further ado, I'll start off. And I didn't have my usual highlighter here, so you'll have to forgive me because it is small print, but I think I can still read it. So some of the bills we've been following, I think I've got about 70 to 80 bills I've earmarked for us. By next month, what I'll be doing is I'll be passing out a sheet for MCAC with links to the actual bills, so everybody can go look at it, and I will have a little bit more in-depth detail. Did we provide the link to the LSRs?
Doing that right now.
All right, and so David's going to provide a link to the LSR page so you can look at all the LSRs that are publicly listed. LSRs are legislative service requests, which are right now just titles of bills. There are some bills that have been published, but none of the ones that I'm going to be talking about. But you can click on the link to actually see the language of the bill on there.
So on that LSR link that's being put into the chat, you can, if there's a particular subject, you don't have to go through everyone. You can enter in as a search on, like, if you want to look on Medicaid or you want to look on any kind of topic. It's not a perfect search engine, but it helps narrow down your review of the LSRs.
You can also look by
There's only,
sponsor.
I think there's only 1,500. So.
Yeah. Only 1,500. And I don't even do that include HB1 and HB2.
So it is helpful if you want to do your own searching.
Yeah, and you can also look by sponsor too if there's any sponsors that you're looking for things, because sometimes the titles don't necessarily provide a very good idea of what's really going on.
Holly Stevens has her hand raised. Holly?
Hi, I just had a quick question about one of the Medicaid to schools bills. It says it requires permission of parents for all services. Is that a change in the law, or is that the current existing law?
If it's still an LSR form.
Yeah, I don't think that's been published yet.
Yeah,
I
generally
thought
today, you do have to, most of there's either an IEP plan or a health plan or something. I think that there are parent signatures on those. What generally you could say is that I think probably the LSR stems from concerns that there can be changes in those plans and that the parents are notified or not of those things. I think is the general issue that's out there.
And Holly, what I can say is there was a bill last year that had a similar sounding title that we were asked to weigh in on, and we did make the point that we didn't really think that this changed how practice currently exists. That's what I can say right now.
Yeah, no, I'll look for it, but I do believe I read the language for that one.
Okay.
I'll look for it and I'll put the number of it in the chat if I find it.
Okay.
Thanks.
Thank you.
I think some of these LSRs reflect the concerns over parental rights as they did last session.
Yeah, that was a very big theme this year was parental rights. And
it's Senate Bill 34, Rob.
Okay, so that has been published.
Okay. So that one's out there. I think I've read that bill, and it deals with when there's a change to make sure that the parents sign off on it.
Correct. Our perspective is it doesn't really change a lot of current practice, but that is out there.
I think last year the bill, each and every visit had to be signed off on, which was
a little bit more arduous.
Mike?
Yes, I can hear you. Can you hear me?
Yeah.
One thing of sort of ancillary, but it's a little sneaky, but it's important to note. LSR 528. It's a bill sponsored by Representative Schmidt. Would ban water fluoridation, community water fluoridation. This is obviously of great import to the Medicaid population because it provides them a great deal of preventive services or preventive health so that they don't go into their dentist's office with extreme decay and other issues. So it's worth noting. I don't think it has a bill number assigned to it yet. But as I said, 528.
Yeah, and thank you for that. We did receive a fiscal and worksheet request on that, so we have been working on that and working very closely with Dr. Penny on that bill as well.
Oh, sorry, Henry. I was just gonna ask out of curiosity, I used to know the number and I don't anymore. How many New Hampshire communities actually have publicly fluoridated water?
I believe it's, just thinking from memory here, I believe it's 17.
That is
There.
correct, Rob.
Oh, wow, look at that. Thank you, Dr. Penny.
Gold star.
I think just the context of that one this year is, well, that's been sort of a state by state issue. There's been discussion at a federal level as to whether they want to come in and have some intervention on fluoride.
Back at you.
All right. So on to the titles. LSR, this is actually, it's going to be a Senate bill relative to parental consent for student participation in the Medicaid schools program. We did just talk about that one a little bit. We have relative to Medicaid pharmaceutical services, that's a department requested bill. Can't speak about it yet, but I'm hoping by next month we can talk a little bit more about it as well. Then there's the fluoridation bill we've already spoken about. Another one is relative to work requirements under the state Medicaid program that will be following.
Rob, I think there are 2 LSRs out there.
Oh, okay. I have one on my sheet, but I can double check that to see if there's another one. This is an HB one. It's by the prime sponsors, Representative Papavici Muller. We have another dental bill that I've been working with Dr. Finney on is relative to the use of general anesthesia, deep sedation, moderate sedation, and dental treatment. We have to enhance consent and accountability in psychotropic drug prescriptions for children under Medicaid.
Rob, I don't mean to interrupt. This is Jake Berry from New Futures. I just wanted to point out, I think Representative Papavici Miller's Medicaid work requirement bill has been withdrawn.
Oh, it has? Okay.
I believe it has.
Yeah. All right. There's another one floating around out there, as Henry alluded to.
I know that Representative Jess Edwards also had one, but I think that was also withdrawn. I don't know if there's another one you're familiar with, but anyway, thank you.
Yeah, I appreciate that. There is definitely one that's still out there and floating around. So
yeah,
it will have to be addressed somewhere down the line.
Sure. Thank you.
Can you repeat the titling on the psychotropics for kids?
Sure. To enhance consent and accountability in psychotropic drug prescriptions for children under Medicaid.
There's a hand up. Christine?
Is that Christine started?
Yeah, Christine?
Yes.
Yep. Hi.
Yes, thank you. Sorry, I just had a question about the workforce bill, or the work requirement bill. It's current statute still, right? So is that why those bill drafts have been withdrawn?
I couldn't speak to why they've been withdrawn, but yes, it is currently in statute at this point in time. Obviously, there's some conflicting law out there. There is a court order. And there's administration views of it as well. I expect the administration to change its view once we have a new administration in. But so there's some conflicts of law out there at the moment. But yes, it does exist in 126 AA.
Thank you.
Mike?
Again, I believe you were referencing the deep sedation, moderate sedation for dental treatment.
Mm-hmm.
And that was sort of filed as a as Plan B. The Board of Dental Examiners submitted rules that would severely restrict oral surgeons and other board eligible people from providing anesthesia without a second provider in the room. It went before JAILCAR back on the 19th, and JAILCAR gave a preliminary objection and sent it back to the board. The board is going to take, I believe, until mid-April to give its response. So it's going to take a better look at that. So the Representative Kofalt bill is still out there, but I don't think it's going to move until the board gets done with its rulemaking.
Thank you, Mike.
Yeah, that's helpful background information. I appreciate that. Moving on, we have relative to state participation in the Medicaid Direct Certification Program for free and reduced price school meals. This has been out there pretty consistently for at least 2 or 3 sessions now. I believe it's more of a Department of Education bill, but we've been lending our support to the agency through providing data and stuff like that. We have relative to the use of electronic medical records. We have directing the dissolution of the Department of Health and Human Services Office of Health Equity, Department of Environmental Services Function for Civil Rights and Environmental Justice, and the Governor's Council on Diversity and Inclusion. We have establishing a commission to study the privatization of the Liquor Commission. Obviously, that's a bill we'll be paying attention to, just given its potential effect on grant advantage funding,
as well as the Governor's Commission on
the Governor's Commission. We have relative to coverage of circumcision in the state Medicaid plan. We also have establishing a committee to study informed consent laws and medical privacy practices in New Hampshire and their impacts on patients, providers, and payers. We have relative to reports by the Department of Health and Human Services regarding Medicaid enhancement for children and pregnant women. We have relative to insurance coverage for biomarker testing. We have making appropriations to the Department of Health and Human Services to increase homeless shelter care management services. We have relative to financial eligibility for the Medicare Savings Program. We have relative to coverage for ear acupuncture as a substance abuse treatment under the state Medicaid plan. There is relative to long-term care eligibility and making an appropriation therefore. We have making appropriations to the Department of Health and Human Services to support community and transitional housing through community mental health centers. There's relative to using enrollment in Medicaid as a measure of eligibility for school lunches, so probably a companion bill to the other bill I mentioned earlier, but I can't say for sure whether the language matches. And we have relative to hospital stays covered in the Medicaid state plan. And last, which is more of a general bill, but something we'll be paying attention to given its impact, is relative to testimony of agency employees in general court hearings. So that's always a fun one. And I'm happy to take any other questions if you guys have any. And I'm expecting next month we can have a little bit more in-depth discussion about some of the bills and the department positions and such.
Let's just remember when we're doing our agenda next month, set a little bit more time for that.
Great. All right, thanks, Rob.
Thank you.
All right, Dave, you're up with enrollment and eligibility.
Great, let me share my screen real quick. This is the monthly Medicaid enrollment and eligibility report. So the first slide is our ex parte rate. So this is passive renewals and it's through February now. You can see since September, we were above 80%. For February, it was 77%. And moving forward, these numbers are somewhat based off of some flexibilities we've been able to take advantage of during, well, not during anymore, but due to COVID and unwinding, CMS allowed states to enact policies to streamline passive renewals to increase ex parte rates. And those expire at the end of June. And two of the flexibilities we utilize are around zero income and 100% of the FPL, which allow us to passively renew a redetermination if the person has zero income in their case file or income at or below 100% of the FPL, as long as we've pinged an external data source for income and received no information that would suggest that they don't have zero income or are at or below 100% of the FPL. So that will impact these rates. They'll probably decrease, and I think we had looked at an analysis, and the impact is about 10% of passively renewed applications are tied to the zero income and 100% of the FPL.
So I just want to translate in Kelly Cap language what that means to me and what it might mean to you. My members, 10% of my members right now may be passively approved through the ex parte process. meaning that their pathway to continuous eligibility is a little more administratively simple. And I need to keep my eyes on this population. This population is gonna require my assistance. If I don't keep my hawk eyes out on them, they could think that they're gonna continuously be approved the way they had been in the most recent years, and they need our support to maintain eligibility. They may still be eligible, they just aren't in the same category, for example, of zero income. They could be low income and still qualify, but something about their income has changed. And so maybe they are on Social Security now. So please be thinking about that as we continue to mention this each month. Okay.
I mean, I would just echo, you know, mental health centers, OPG, who help their clients to ensure that they have continuous enrollment. You know, obviously this increases our administrative efforts if, you know, a significant number of our folks are no longer passively renewing, so.
It's like, I think we have a hand up too.
Yadon?
Hi there, Dale Janae from Disability Rights Center. I'm just curious, does this chart include, is this just adults, or would that passive enrollment also include children who are enrolled under like a Katie Beckett program?
The passive renewal rates here is for the whole Medicaid population, so it's anyone enrolled in Medicaid. And this is our trend of enrollment from, and you can see on the far left-hand side, essentially the start of the pandemic, and then on the far right-hand side is where enrollment is as of January 6th, 2025. We have a couple other slides on this, so I'm gonna skip ahead because I think they're a little bit more interesting. This is a point in time percent change from, it looks back just over a year ago from November 1st of 2023, and shows the differences as of the first of the month, what the enrollment trend for each eligibility group was. And so here at the end of 2024, you can see a couple of jumps in both the adult expansion, which is this brown line up here, and then the children's groups down here, which are the purple and yellow ones. And I think these jumps are largely driven by, I think, open enrollment on the exchange. So if someone applies for open enrollment on the exchange and it looks like they're Medicaid eligible, the exchange transfers it to Medicaid, and Medicaid will do a determination. So I think over November, December, we've seen more Medicaid applications, and it's clearly resulted in a jump. And I think it was about a net 2,000 gain in that time period.
Dave, can you comment? I'm just looking at the gray and the pink line in the adult group. They seem highly volatile, up, down, up, down, up, down, up, down. To what do you attribute that?
Some of it may be spend down. So they'll open spend down, become enrolled, and then the next month, when they haven't met their spend down, they technically show up as a decrease.
Yeah, okay.
This is based on the first.
Yep.
Depends on like how the end of the month kind of falls to in terms of what you might see there. And I think from the first slide, we're still running about 7,400 plus people more than we had at the time of the public health emergency was declared.
We're 4.2% higher than we were March 16th of 2020, so 7,400. Most of that is in Granted Advantage. Granted Advantage is up 15.9%, so 8,159 since March of 2020. And then standard Medicaid is a little slight decrease, 0.5%, 715.
We do expect I guess, two things about the Granite Advantage. One is, I think more people use Granite Advantage as an entree point while they're waiting for things like disability to play through. That's been much more prevalent, I think, than it was maybe when Granite Advantage first initiated. And then secondly, the people who are applying for exchange coverage will end up being referred to us. Sometimes there's that group comes in and then goes out fairly quickly. So we think that you'll see, I think January is an anomaly in terms of the increase. I think we'll probably be closer to the 181, 182,000 ultimately.
And this is sort of the same look as the other slide, but just broken out slightly differently.
Smooths out some of that.
Yeah, you don't see the jagged jumps. And so this is our dashboard for adult redeterminations. Due to the holidays, it isn't updated through the end of December, but it's updated through December 18th. But you can see here, there were 8,156 individuals up for redetermination. 6,955 had completed. The large portion of them were passively renewed. 6,804. And this is the same look, but for kids. And so there were 4,405 kids up for a redetermination in December, 12 closures, 3,793 completed a redetermination, with a large portion of them being passive, with 3,709.
Only 12 closed, that's amazing.
But you have
Yes,
600.
there's 600 pending.
Yeah.
It was as of
Overdue.
December 18th. So I'd expect to see, the non-passive group would be a little higher at the end of the month. And this is the waiver population as a whole. So there were 1,280 up for redetermination, 1,089 completed the financial reading, and there was one closure. A large group were passively renewed, 1,070. And there is a pending total of 190. And this reflects both, one, that it was pulled December 18th, but also the waiver population gets an extra 60 days after their redetermination month. So if they haven't completed the redetermination, so for this group of December, if they hadn't completed the redetermination as of the end of December, they get an additional 60 days, but they show up in the pending overdue reading group. And this is just a further drill down in that waiver population to look at the CFI specifically. So there were 360 that had a financial redetermination, 313 completed. There were 0 closures as of December 18th for the financial redetermination, and 307 of those were passive. And this is another drill down in the waiver population to look at nursing facilities. So there were 340 that had a redetermination, 1 closure, 232 completed. And of those 232, 224 were passively renewed.
Dave, just to be clear, pending / overdue means not just overdue.
Right.
Okay,
Yep.
Thank you.
And it includes, so there's a portion here that are pending because they have until the end of the month to complete it, and then the extra 60 days.
Yeah, thank you.
And this is our CMS reporting template, and this is through the end of December. So there were in total 12,561 renewals due. 501 were in progress as of the end of the month. But the key one right here is 92% of individuals retained their Medicaid. So that's 11,093.
Pre-pandemic, the number was probably in the 70s.
Yeah. And we've seen, a number over 90% now for 10 months or so, quite a long time.
Okay, Dave, something in the chat.
Oh.
Cheryl Frey asked, David, can you provide the link to your Medicaid enrollment and eligibility update? Or
We'll actually send it
Oh,
out.
yeah.
We'll send it, yeah.
Yep.
So I'm just thinking about how, you know, certainly since the public health emergency, but I think even predating that a little bit, there was sort of this recognition that disruptions in eligibility have health consequences which generate more costs, right? So there's been all of this attention to ensure continuous eligibility. And I guess, you know, I'm wondering, is there any sort of chatter at the federal level about sullying the nest a little bit in an effort towards austerity?
I think if I'm hearing you correctly, is, you know, is there, with the austerity moves maybe at a federal level, is there a chance that some of the churn that we used to see might reappear? I think that's possible. Which I think.
I won't editorialize, but it's, you guys have worked so hard, it would be a shame to see all that eroded.
So you raise a good point. I think one of the things that we need to do is to get the word out there about that, you know, the flexibilities in the time frame are going back to sort of pre-pandemic levels, which means, you know, people need to pay closer attention to that. But I do think that, you know, some of the things like that we've included in the program, the MCOs have incentives to reach out to members as well to support that efforts. We've been continuing those and I plan to, but I do think it's, and then we have Vern's team Vern, you might just speak to what you're doing. Is that coming up?
It's coming up.
Okay,
Yeah.
so maybe we could just jump to that.
Yep.
So what we're doing, that goes above and beyond even what the flexibilities are in terms of the Medicaid medical team, what they're doing.
Yeah, thanks, Henry. So Vern Clow, Medical Services Administrator. What we have been doing is the MCOs and the Medicaid Medical Services Unit have been making outbound calls. And so this slide shows what we do is we call for the previous month. So in the month of December, we were calling for anybody who closed during the month of November, who had not completed their redetermination or their verifications. We did see an increase in the number. The previous month it was 721. We had 878 individuals on the list this month. We did reach 273, or the MCOs reached 273 of them. So we stayed constant with the amount that we were able to actually engage, going from 32 to 31%. Of those that we actively engaged, or they actively engaged, 32% had actually completed their redeterminations and were open. 31% were aware of the fact that they needed to do their redetermination and were open. And we saw a number, 17%, which actually had new insurance. And one of the things that I wanted to point out about that is the majority of those actually were in AmeriHealth. And that may be because AmeriHealth has a higher population of Granite Advantage, and those individuals are possibly at that level where they're able to, through employment or other means, secure insurance through the marketplace or through an employer. This month, none of the individuals that were reached had any questions regarding the child income difference, income limits being different. So that was good. And we're seeing our numbers, even with the increase in outbound calls and those that we're able to reach, stay pretty constant. If we could go to the next slide. So the Medicaid medical unit makes phone calls out to individuals who the MCOs left messages for they could not reach. And here again, we saw an increase in the number of calls that were able to be made. The previous month, the Medicaid unit made 110 outbound calls. We were able to do 180 in the month of December. Looking back at those, we see that of those that we reached that the MCOs had left messages for, we had a 50% completed their redetermination and were now open. 19% had new insurance. 7% had done their redetermination but were found ineligible, and 19% were aware and they were working on it. So we are seeing an increase in the numbers that are either being able to be newly insured, which we're capturing through this call. We probably would not know those numbers without these outbound calls. We did see.
Can you,
sure.
just a quick question. How many attempts do you make for each individual before you sort of say, like, we're not going to get them?
So 2 MCO, then you're stuck.
Yes, so the MCOs, they make as many calls as they need to try to reach people. They have to make at least one, but the incentive for them is to reach people. That's where it matters. So they're incentivized to reach out as many times as they need to in order to get to somebody. With the Medicaid unit, we make one phone call. And also, if we get an answering machine, we will leave a message as well, asking them to contact the state in order to do the redetermination.
It's an incentive on completion, so
Yes.
it's not whether they remain or there's no adverse incentive to the MCOs. There's actually, I think, an incentive, whether they get an incentive or not, to keep membership.
Right. Yep.
I think it would be helpful for a future agenda item to talk about what the redetermination continued flexibilities are. Like the 60 days, because I have to remind people of that all the time. I mean, 20-year case managers, I have to remind them that because someone didn't submit their bank statement and now they're been told, right, that they didn't submit all their verifications, that they don't need to initiate 10 days later an entirely new application. They need to submit that verification. So I think formalizing a conversation about it would be helpful to help us to reinforce that in the community.
That's a good idea, and especially with the changes coming up too, it
Yeah.
could be helpful to, highlight, because the volume of applications that do not get passively renewed that require someone to verify their income or verify something about their case.
Yeah.
And there is a reconsideration period, so yeah.
Thank you.
Yep.
Unless there were other questions, that's what I had, Dave.
Okay, thanks, Vern.
Thanks.
And there was just one other slide that I had shared with the MAC last week, but I'll just flag here. It's the October and November MEA reporting, and this is MEA stands for, it's the medical eligibility assessment, which is the medical determination of if an individual is in CFI or nursing facility care. They have to do the financial redetermination. They also have to do a medical redetermination to assess whether or not they meet the level of care necessary for that benefit category group. And it's broken down into individuals who remain open in Medicaid and then closed in Medicaid. So for October and November, for individuals that still remain open in Medicaid, there were 297 MEAs completed in October and 196 completed in November. for October of the 297, 268 met level of care. And there were 29 MEA denials. 21 of them were for not meeting level of care, and 8 were for fail to provide documentation. And so if you move over here under October, where individuals, breaking out the individuals who closed Medicaid, there were 10 total closures due to the MEA. 8 of them for not meeting level of care, and 2 for failing to provide documentation. And in November, there were 196 MEAs completed, 147 net level of care, 49 MEA denials, 39 for not meeting level of care, and 10 for failure to provide documentation. But moving over to the closures in Medicaid, there were 11 closures due to the medical determination, 9 for not meeting level of care, and 2 for fail to provide documentation.
Cheryl?
Questions?
Cheryl?
Yes, hi. I know we've discussed this issue before because, NHLA and I think case managers have acknowledged that there seems to be an increase in these denials based on failure to meet medical eligibility criteria and these redeterminations, and it seems much higher than it's ever been. And I'm just wondering if we could get information that shows what the rate was pre-COVID, pre the public health emergency, because it seems like it's an increase from the past. And we're trying to, it'd be helpful to get to the bottom as to why all of a sudden all these people who have been found eligible for many years are now all of a sudden being found to no longer meet clinical eligibility for the program.
Are these all redeterminations?
These are all redeterminations, and similar to the financial redeterminations, they were during the public health emergency. There were no
3 years.
Yeah, which was 3 years. So there were no medical redeterminations once someone became eligible during the PHE.
Even longer than 3 years or so.
Just a little, yeah.
Right. Well, I mean, is it possible to find out? I mean, it does seem like now that we're past the health emergency, and I don't think that's the issue anymore, very little of it. It seems like there's still a ongoing stream of these denials that we have never experienced before.
So I've got a meeting today with Stephanie. Hi, Christina Ickes, Bureau of Adult and Aging Services, Long-Term Care. And so I've got a meeting this afternoon with Stephanie Russell because I wanted to go over some of the numbers last week. But in general, the public health emergency had ended and we had started with the redetermination unwind, if you will, in November of 2023. And so I suspect that we're probably at about the end of the hill or going to start to see a drop in the number of cases redetermined ineligible within the next year. I think that if we're going to be looking at a number, pre-pandemic versus post-pandemic, that number could seem higher because of that extended period of time within which we had the COVID pandemic flexibilities.
Mm-hmm. Well, I mean, I guess we could try though by looking at like a several-year period prior to the public health emergency and what we're seeing now. I mean, all I can say is that virtually every case I've had, the person has been found eligible without even a hearing, because either they didn't have, you guys didn't get all the medical information, or the MEA wasn't completed accurately. So it just seems like there's a lot of people being found ineligible when their medical condition has not changed at all, or if anything, it's gotten worse, yet they're being found no longer medically eligible. So I don't know, maybe it's good to figure out why that's happening.
I think the challenge to compare the apples to oranges would be that prior to the pandemic, we didn't have a period in time of flexibilities.
I'm sorry, didn't have a what?
We didn't have a period, an extended period of time with the flexibilities where there might have been people who were on the program for a year or longer. So that's my just thumbnail is. I think we
Well,
might
yeah, I
challenge
don't, maybe, I guess it does require a further, a deeper dive, but all I can say is I've also had ones where the MEAs had been done yearly. So it's not like it's just been a matter of, 3 years passed, there was no medical determination, no assessments done, and all of a sudden they're no longer eligible, but we could, yeah.
For a cohort of people within the public health emergency, however, there weren't even MEAs performed.
Yeah.
So I guess it would be interesting to know of people who closed, how long they had been open and how many MEAs they had had over the duration of their eligibility, to see if, just to sort of rule out that something different is going on that is unrelated to the flexibilities.
Right.
Because I look at these and I share Cheryl's concerns. And then I have sort of a second concern, which is, the low completion rate. Like, is that just contributing to the backlog? So if 753 were due, but only 297 were completed, if I'm seeing that correctly, that's, 400 and something that didn't get done.
And some of them are bridged because we didn't get documentation. So if we didn't get documentation, there's additional time for the documentation to be provided. And so they show up as due, but they're kind of pending or in progress.
And we look at factors like, are they unable to contact them? Are there rescheduling? Are people not there when the assessors show? So there can be a lot of factors that weigh into that, but we do then extend a period of time with these bridging approaches.
I guess that what you hear the membership saying is, we're concerned for people who are eligible, that you ultimately agree are eligible, but that get denied in the process. And we're interested in finding a way to mitigate that. And is there a conversation that we can have? Or is there something you can bring back to us on ways that we could look at that and address that? I think it's a fair ask. So maybe we can leave that with you and have that conversation again. We have a couple more comments up here on the board though. Joan?
Yes, I'm really interested in what is the criteria in the medical assessment, and then who actually certifies the assessment. If they're in limbo, as they say, and there's no documentation on the assessment, what is your criteria to actually remove them if you don't have a proper assessment of their status?
I think similar to sort of the provider relations training question that came up earlier, maybe a good baseline would be to do a presentation of what actually happens and what percent of the denials get overturned on appeal. That would be, I think,
right.
Maybe a good place to begin is kind of get everybody up to the same. I hear what you're saying in terms of we share the same interest of wanting to people who are eligible who don't remain open is creates work for everybody and potential harm to the individual. So we don't want harm to happen. So I think maybe if we start with some basics, make sure everybody's on the same.
I like that.
That we can then maybe learn from each other in terms of how it could be better.
Thank you.
Sounds great.
I like that too. Thank you.
We have another hand up, Madeline.
Hi, thank you. Just wanting to say, that I've been hearing the same thing that Cheryl's been hearing, and we've been experiencing that at our own case management agency. So I'm really glad if we can just do a deeper dive into this situation, because there are folks that have been on the program for years and are closing, and the staff, everybody is just like, what the heck? So anyway, that's all I wanted to comment.
The one thing, in terms of the early experience as we started to re-engage in doing these, this report that you're looking at didn't exist previously. It's a function of trying to create some transparency to what's going on. So I think in terms of this is the first time this report's been available, not this particular month, but it started
around August.
As we started to hear concerns, and there are certainly case-specific situations that need to be lifted up versus systemic issues. So there, it could be like an assessor that early on we had an assessor that we needed to do some work with through the entity. So that just getting everybody up to the starting line again, there's a contractor who does the assessment, but the department staff actually makes the determination. And so it's a multi-level process. So just laying that all out so people understand what's going on, and then lifting up some examples may help us find ways to improve, just like we've been able to improve in other.
Yeah, also analyzing the ones that get turned over on appeal and where that, and what led to that. So that might be helpful too. Yeah, that's great. Thank you.
And just understanding the appeal process too, that an initial denial with an appeal buys, they're not actually being closed, they're left open during that appeal period if they ask to be. And so that it could be, clarified and resolved in a way. So I think it makes sense to spend some time to get everybody up to the same.
Right, this is a great discussion. I am mindful of the time.
Just one thing in the chat.
Okay, one more question and then we need to move on.
Cheryl Frey would like more information on bridging these cases. I've had clients that have had 5 to 6 bridges in a row.
That's an example of us trying to make it work for someone, but again, I think to do it justice, it needs time.
Okay, super.
Joan put her hand up again.
Yes, I really appreciate what you said about bridging the gap in the assessment. I have been working in long-term care settings and supports, and as a dental provider, as a preventive therapist, and understanding that we only look at grooming, and so I'm very interested in the assessment process, because I'm not exactly sure whether oral health is getting its full view and full deserve on the medical criteria. So that's where I stand on that. So appreciate the process of moving forward and trying to look at all of the aspects.
Thanks, Joan. Okay, we really need to move on. So there's been a request for a while to talk about what CCBHCs are. I think Evelyn is here to enlighten all of us, except for Kelly, who knows a lot.
Actually, it's not me, but Eve, just understand that Patricia Hardy and Cynthia are present to participate, and they'll jump in as appropriate.
Okay, fabulous. I will share screen, hopefully the correct screen.
And for everybody in the room and on the call, CCBHC stands for Certified Community Behavioral Health Clinic.
So not sure who we have here for this. I tried to do kind of an overview that goes high level for anybody who hasn't heard of CCBHC. So hopefully be informative, but not too duplicative for people. So my name is Evelyn Allen. I often go by Eve. I work with our Bureau of Mental Health Services under the Division for Behavioral Health. I'm grateful for the time to come and talk with you today. If you have questions, please feel free to reach out to me afterward. I'm going to try to go a little bit quick because I think we're behind on the agenda and I want to be respectful. Unless you don't want me to go quick.
We can go quicker elsewhere, so do
what
you need to do.
So what is a CCBHC? It's a Centers for Medicare and Medicaid Services model of providing behavioral health services. It looks at behavioral health as being both mental health and substance use disorder. The goal is a higher quality of care and also increasing a higher access to care. And it also sets up a payment-based model where the true cost of delivering services is at the core of how the model is implemented. The model has 6 areas of program requirements. These include staffing, which is driven by a community needs assessment and also based on a robust staff training. It looks at the availability and accessibility of services, so they're timely and meaningful. There's 24/7 access to crisis services, and also is aimed at decreasing barriers such as inability to pay or having a defined place of residence. The third part of it is looking at care coordination and having agreements with other area providers, such as your federally qualified healthcare centers, outpatient and acute healthcare settings, and social services. It looks at the use of health information technology and also has a big focus on improving transitions and level of care for individuals who are moving out of those more hospital-based settings back into the community. The fourth program area is looking at the scope of services, where there's 9 specific areas of service that are required, as well as increasing the person and family-centered methodology and more of a recovery-oriented care model. The fifth part of it is looking at quality and reporting. So there are specific quality measures that are required, as well as ongoing tracking and looking at quality improvement. And then the last portion of it is looking at the organizational authority and governance, which has requirements around having more lived experience for individuals involved in the oversight of the programs, as well as having the appropriate state accreditations. So of the 9 required services, there's outpatient mental health substance use services, person and family-centered treatment planning, community-based mental health for veterans, peer and family support services, targeted case management, outpatient primary care screening and monitoring, psychiatric rehabilitation services, screening, diagnosis and risk assessment, and crisis services. So with the 6 program requirement areas, there are 307 discrete criterion. What we did is we looked at the Substance Abuse and Mental Health Services Administration's checklist, where they created a breakdown of what they felt were all the criterion points under those 6 program areas. We numbered each of those to get that 307 specific criterion points. So those break out as 61 of them related to staffing, 37 for access and availability, 54 of them around care coordination. The majority, 116, are for the scope of services, which is those 9 services I just went over. And then 30 are for quality and data reporting, and the last 9 are for the organizational authority, governance, and accreditation. I do have links on here. I can PDF this and send it with hyperlinks, so that helps people afterward as well. New Hampshire has the opportunity within the criterion. There are points that will say, other state requirements included. So New Hampshire identified several requirements to add into those criterion. Under staffing, New Hampshire has opted to have a requirement that CCBHCs will provide 2 to 5 what we're calling community health workers, or they can be your peer specialist whose work is aimed at engaging underrepresented populations that are identified through the community needs assessment. On the scope of services, we identified what are the New Hampshire required evidence-based practices, which is a list of evidence-based practices that are currently in use by our community mental health centers. So we identified those as the basis for what we would require for evidence-based practices. We opted to do the required BMI, blood pressure, and laboratory assessments for the appropriate screen for cardiometabolic risk concerning psychotropic medications and BMI status. And then we also identified
that all individuals with SMI, SPMI, SED will have targeted case management. Under the quality reporting area, we're identified that CCBHCs will report on all of the required and optional CCBHC quality metrics. There is a whole lot more detail on that topic, which would probably be a whole other conversation later on. But there is a series of quality measures that are required, and then some of them that are optional for states to provide, and New Hampshire identified to do all of the optional ones. In the last section on organizational authority and governance, New Hampshire has identified that we would start with the applicable community mental health center programs for their accreditation, certification, and licensing. This slide gives a breakout of what are the evidence-based practices that are currently required for New Hampshire CCBHCs. And again, this list was developed based on what are the EBPs currently being implemented by our community mental health centers. There's a lot of text on here and small print. I'm going to move ahead knowing that we're trying to be cognizant of time. So what is a CCBHC demonstration? It is a cross Health and Human Services partnership with SAMHSA, CMS, and the Assistant Secretary for Planning and Evaluation to improve the behavioral health of Americans. It started with the PAMA Act in 2014. That then led to the organization and release of planning grants to work on the CCBHC development model. By 2016, they started the first demonstration with 8 states. In 2018, there was a release of another series of planning grants for states to engage in developing and exploring the model. It was 2021, 2022, they added 2 additional states to the demonstration. They then had in 2022 the Bipartisan Safer Community Act, which identified that they could add 10 states to the demonstration every 2 years. In 2013, there were additional planning, 2023, thank you. There were additional planning grants released, and then now we're at 2024, this past year, where the next 10 demonstrations were awarded. Through all of this, they have been gathering information. There's a link at the bottom of this slide, which goes to the page where they have the annual evaluations posted, where the National Health and Human Services Secretary submits their annual report to Congress, speaking to what the impacts are showing on the access to community-based mental health services, the quality and scope of services being provided by the CCBHCs, as well as the impact the demonstration has had on programs at the federal and state cost for providing those full range of mental health services. So for New Hampshire was one of the 10 states added to the CCBHC Medicaid demonstration as of Monday, June 3rd, 2024. New Hampshire started exploring the model in 2022. We received the planning grant in March of 2023. We got a no-cost extension last year, so our planning grant will be ending in March of 2025. Through the planning grant, we identified capacity to apply for the demonstration, which we did, and we also were able during that time to look at certifying 2 of our clinics in state as New Hampshire CCBHCs to support the application for the demonstration. In December, we received an application for a 3rd clinic to become a New Hampshire CCBHC, and that one is still under review. January 1st, so just 2 weeks ago, we went live in our implementation of the CCBHC demonstration. And we will be exploring in the near future interest and capacity for any additional programs in New Hampshire to apply to become New Hampshire certified CCBHCs. Go quickly over this one. The national demonstration is showing successes as far as the impact of the CCBHCs, where they're showing that it's expanded the number of individuals served by an average of 33%. We're also seeing that it has an impact on hospitalizations. Some states have found that it's had a decrease in their emergency department use by as much as 18 to 47%. And inpatient care decreased by 20 to 69%, varying by clinic. Again, I'm gonna share this out, so I'm not gonna go over word for word, just trying to be more.
Can I just
flexible.
reinforce the second bullet that you have on there, that it's also had an impact on staffing resources?
Absolutely. Okay. This slide is kind of the similar information. The projected impacts from doing this demonstration is that we're looking at utilizing CCBHC to improve our access to our community comprehensive behavioral health services for Medicaid individuals and reducing the costs or maintaining Medicaid costs via reduction in the acute care. The goal would be that it's anticipated New Hampshire is going to have better access to behavioral health services for our population, including delivery of substance use disorder services. And then we're also with the goal of prevention and that the behavioral health access and quality increase with a focus on care coordination is going to help reduce the all-cause emergency department visits and hospitalizations.
So I guess if I could just, later on in the presentation, we're talking about the recent MCO contract. So additional funding was put into the MCO contract to stand up the two CCBHCs. It's important, I think, to note that from your prior slides that where the savings show up and the investment is in different areas. And so I think one of the things that'd be good to hear from the centers that have started is sort of like, you make sort of the what's the thing, an ounce of prevention is a pound of cure. I think that's sort of the philosophy here approaching CCBHC is that by making an investment to integrate those more complex behavioral situations that are dually involved, that you won't see necessarily immediate savings, but that over the long run, you will.
Doris Lotz asked, what are the startup costs, if any, to the CMHCs?
So what the way we've strategized the entry with the planning grant and the demonstration was that in New Hampshire, prior to our applying for the planning grant, there were 3 of our CMHCs who had independently applied to SAMHSA to obtain clinic level grants for their CCBHC model. So because those 3 centers already identified their investment in applying for those grants, I think 2 of them had the clinic level grants awarded to them. The 3rd one applied for a follow-up grant that was awarded shortly after our planning grant initiated. Those 3 programs had federal funding that supported their capacity to further explore and implement the CCBHC model. I see Maggie has her hand up.
Keep going. Keep going.
Oh, in terms of the funding, I can't speak to those programs in terms of how that funding from the federal government has been utilized for their implementation costs, but the state utilized the programs who had those grants because they had the capacity to utilize that federal funding in support of their operationalizing the model. And then as we pivot into demonstration, the goal is that through the demonstration, the PPS model will support their sustainability of the model going forward as they've implemented it.
Maggie?
So my question really is the dollar amount for those centers from their grants, and that it does not appear to be a hard leap to say, and I would ask the people on the phone, Cynthia or Patricia, did it take those millions of dollars or whatever it was from SAMHSA for you to be in a position to move forward today with doing this? Because I think that's important if the vision of the state is to move to CCBHCs, to understand the upfront cost and time. And so if Cynthia and Patricia could comment on how long the grant was for and how much money it involved and how integral it was for them to be able to go forward, I would appreciate that.
I can start. This is Patricia Carty from the Mental Health Center of Greater Manchester. So the Mental Health Center here started before the state had even started their planning grant. We got an initial 2-year grant. These grants are generally $1 million a year and now they are doing 1 million over 4 years. It speaks to the issue of what it takes to stand up all that is needed to meet the criteria and to have all the components sort of that you need to be a CCBHC. So to the question of, and I think you can see that all the improvements that were on the slide that talk about the changes that you see and the improvements that are made, you can see there was a little thing that said over 4 years. And I would suspect that a lot of the people sort of measuring data, it's over this 4-year period. As Henry said, you're not going to see initially maybe the savings, but it's really going to come, and it comes from a variety of sources. I think that's the complicated part of this, is that you're doing things that impact not just behavioral health and substance misuse, but you're also doing things that impact and improve people's health status, and doing some things preventatively so that you can really work collaboratively with primary care and within a primary care system so that you're providing whole health care. And so the savings come from a lot of things. And so would I say that you need the startup money? Absolutely. There's a lot of building of infrastructure that comes initially, both from a qualitative standpoint, but also from a health informatics standpoint, from how your electronic record is set up, what's needed, and those things generally cost dollars. It's also about really sort of, you saw one of the items was about, community health workers and peer specialists. Well, how do you build out more staffing in order to meet that criteria? And generally, when you apply for the grants for your 4 years, you have goals that you're trying to hit with those dollars per year, right? So you start with one thing, and if you're building infrastructure, you then might move to the next thing. And so you're really, it's building on all the things that you need to accomplish. This is also, the linchpin in this model is care coordination. And so that means that you have to have a lot of relationships that are more formal than you may have had in the community to really be able to do good care coordination across everyone, the person's healthcare needs. And being able to do that also requires a lot of time and a lot of building those relationships and figuring out, one of our biggest challenges always is that, our electronic health records don't play nice with each other. And so being able to sort of share information in a way that is helpful to everyone involved in the person's care is sometimes takes more labor than we would like. And hopefully in the future, we'll get better ability to have integrated electronic health records. But the other thing that I think is really critical within that is, in this care coordination is really making sure that you are able, through like a health informatics team, to show your outcomes, show your data, let your data tell a story about how health is improving overall. And in our startup, we have preliminary results in our Pro Health Clinic, which is our integrated primary care clinic, that is starting to show results. And that's what you're really looking for. But you have to be able to have a system that allows you to do that in people. who can be doing that for you on the regular. So the grants have been critical to the startup, in my opinion, around being able to accomplish all that you need to accomplish in CCBHC. I don't know, Cynthia, if you want to add to that.
Sorry, folks, due to the timing of you all being a little delayed, I did have to jump into my car, so hopefully you can hear me okay. I mean, I would certainly agree with what Patricia said. We use a lot of our funding, and we still have some funding left at this point with SAMHSA, but a lot of it has been around infrastructure, around the data, as Patricia talked about, but also around standing up some of the services required that we didn't currently have. We did not have a specialized veterans team, for example. We also needed to put some time and resources into standing up an advisory committee, which is a requirement of being a CCHC for getting more consumer client input into our governance. So there's a lot of cost to standing up things that we haven't typically had funding to do here in New Hampshire. That are some of the requirements that Eve so eloquently shared, and it requires time and resources to stand them up.
How you doing over there, Eve? How many slides do you have?
Well, does the question?
Lisa DiMartino asked why not all the 10 mental health centers included in this.
So our planning grant initially was to explore New Hampshire's capacity to engage in the model with the intent of would we be able to apply and be part of the demonstration. For our other New England states who are also in the demonstration, they range between, I think, 1 or 2 sites to having, I think one of them might have as many as 10 sites. Talking with our kind of more national counterparts around what each state has done. I don't think any of our states have opened it up to like full state implementation. They've all had a handful of sites to initially stand up, pilot with, and then expand. So our planning grant aimed at, we identified our 3 programs who had the clinic level grants issued to them, starting with them as they already had initiated those. The grants required those centers to be working on implementing the model. So it was, it aligned and made sense for us to initiate with those 3 programs to start. Our hope is that our federal partners will be issuing in the next few fiscal years additional grants so that if other programs are agreeable, they could apply for those SAMHSA clinic level grants, and we could work with them if we have capacity to bring on more. Otherwise, our intent is to do the demonstration for the next 4 years with hopefully 3 CCBHC sites to see what the impacts are so we can then bring forward, does this make sense more globally for a statewide model, and how do we go forward from there? Okay. So bringing back to the slide deck, there are 4 payment models that are part of the CCBHC demonstration. There's a prospective payment system for a daily rate.
And I suggest this would be a good area where you could economize.
Okay.
That state chose method 3.
We did. We chose PPS 3, which is a daily rate with a special crisis rate carved out of it. Being mindful of time, well, I should move. So the PPS rate is a standard rate with a special carve out for crisis for ARPA compliant mobile crisis services. We did not have any special population modifiers, and the PPS rate is applied for Medicaid beneficiaries who receive services. I'm just keep scooting ahead. So New Hampshire is doing all of the PPS, all the CCBHCs have a clinic specific PPS rate. The process is done with each center separately, where there's a cost reporting process. They'll go over the implementation plan for the staffing needed to meet the community needs and the CCBHC requirements. It goes over the anticipated costs for the service provision, the direct, indirect, and visits that would be aligned with the data for what their program capacities and services look like. And then all of it goes through a review. We've used Myers and Stauffer. And then from this comes out with a clinic-specific rate of what would be the true cost of services to meet a PPS model. And then the department looks at that rate using the enhanced Medicaid drawdown to make up the rate to the provider, and we'll do rebasing after the first year to look at the.
Yeah, actually, I think we're doing rebasing after the second.
Yep.
Oh, okay,
Yeah.
okay.
2 years.
Sorry.
2 years, yep.
So there's two ways of becoming a CCBHC. One of them is to apply to become a New Hampshire certified CCBHC for our demonstration. The other way is to apply for a SAMHSA CCBHC grant directly and become a CCBHC by SAMHSA, but not be a state certified CCBHC. Any entity that applied to be a CCBHC through SAMHSA and obtained a grant could also apply to become a state certified one. And I think that is from what we've heard from Manchester and Nashua has been the optimal way to utilize the federal funding to support the operationalizing and then utilizing the state certification going forward. So our certification process, we'll go over this quickly. New Hampshire utilized that criterion that was published by SAMHSA, and we utilized a contract with Brandeis University to develop a tool for us that goes through and rates each of the criterion, those 307 points. And then the tool auto calculates out what percentage of compliance. We do yes, no, planned, or in progress rating, where if it's a yes, the criterion's met, there's a full point. A no for no is for no compliance is a 0 point, and anything planned or in progress, they get a half point on. Those points are all tabulated to come up with a percentage of how much of that program requirement area is being met. In going through the tool, we look at overall score of 80% to all of the 307 as being sufficient to become fully certified as a state CCBHC, with a minimum of 75% met in each of those program requirement areas. And this is right now looking at initial certifications. We don't have any renewal certifications, so we're not sure if that may change when we get to renewal, but we have a demonstration to kind of map out those pieces and make decisions. In the certification process, we did have 13 core elements that we identified as pieces that are important to the model, that for the programs, if they meet the 80%, but there's a core, what we call the core element that was still in process, we're going to work with the provider to make sure that we continue to move toward having that item that was planned or in progress moving to a yes during the course of their certification. I think all of our CCBHC certifications under the CCBHC model are for 3 years. That's the last slide. So we do have our email address on here, as well as there is a public facing website where we have our demonstration application. There is a public facing single page sheet that was created with the Public Information Office that gives us a high level statement of what CCBHC is and the services, as well as there's a couple of other documents that we have put up there, including our certification guide, which includes the certification process in a little bit more detail, as well as a copy of all of these 307 criteria in the application and how we look at suggested evidence for meeting those criterion points. Any quick questions?
If it's not quick.
It might be good to just hear from the centers in terms of like sharing. I think we kind of went through sort of the process of becoming, but what is it they're going to see differently for their population that they're serving?
Tricia?
I don't know where to start kind of on that's a kind of a big question. I think the most sort of, I'll start with just by talking about the most visible thing that you might see from the standpoint. One of the big areas obviously is access, and people talk a lot about, access to services, and being able to serve folks. You saw some of the statistics and you might say, well, how are they serving more people? It's not like initially you have any more staff or your vacancies are the same as they were from one day to the next when you get one of these grants. But one of the things that we've been able to do, and Cynthia as well, is that we've moved toward the model of open access. So this took a lot of planning within just to figure out how we would do this and how you would have surge capacity when people come in. But basically what that means is that instead of having appointments, you have an open access model that allows people to walk through the door at a location and get seen in that moment. So sometimes people call and sometimes they get the information, but a lot of people now, they're asking about, appointments, but really we have an open access model. We started that in July of this year, and of last year, sorry. And, it has been, we're still in some ways, some days working out the kinks, but we have really been able to not have the long waits that we were having before. That has been a game changer in many ways. And utilizing the staff that we were utilizing prior, but also continually evaluating, what that open access means. And you can't just stop at saying that the appointments are, and this is kind of what CCBHC does when you're looking at these kinds of things. It's challenging how you look at that model. So you can have open access, but you have to ensure that the open access is also hitting things like social determinants of health, which again are a big thing under CCBHC. So you can have open access, but if you haven't cleared the decks for people who might have transportation problems or people who have childcare issues or language barriers or any of those things, as examples, you have to really figure out, how do you identify those needs? You have people who may have mobility issues. And how are you going to address those with folks who can't just say, well, come into the building that you're having this open access in? And so, in the last 6 months, we've been really looking at those kinds of issues and how do we address that within an open access model, because that means true open access when you've addressed sort of all those things. So that's sort of a visible example of some of the changes you make within the context of what you're doing. And there's, Eve sort of showed you this slide that there are like 307 things that you get evaluated on. And pulling those apart has been a huge endeavor. And because you have to meet 80%, we're still evolving in all the things that we're trying to accomplish and fine-tuning some of the things that we have in place. So, there might be questions about other things, but that's, it really is a significant change in ensuring that you're doing things in a way that hits all the necessary components and sustains those components.
Thank you, Patricia. So the conversation really evolved from a couple months ago when we used the acronym CCBHC in a meeting, talking about the MCO amendments. And that's why we brought this presentation. I think a lot more detail than I anticipated you would bring, Eve. Thank you so much. And thank you, Patricia and Cynthia, for sharing. And we certainly can entertain questions for future agenda items as we move forward.
I think we should program in a live action kind of thing, what's actually happening with Cynthia and Tricia and future meeting here.
Great.
Because I think, it's a huge undertaking to, as you get a feel, begin to get a feel from today's presentation, how it actually is helping people in the community is really, I think probably what people who are on this committee would
Yes.
like to understand even more.
Agreed.
I know, mindful of time.
Right. Thank you.
Thank you.
I know one thing we didn't share at the top of the hour is that Scott Beckwith wouldn't be available today to do the DDU update. That information will be sent out, so that'll save us a minute. Okay.
The over 90 days came down by 100 or so cases.
Yeah, that's great.
Outstanding. So let's see if we can fly through the department updates. Okay, good morning. Sarah Finney, Medicaid Dental Director, reporting on the adult dental benefit for this month. We had an increase of another provider. We had a big jump last month, so don't expect that every month. But we did get one more, so we're up to 189 providers at 132 locations.
That one provider had how many dentists?
Oh, no, that is per dentist. I think the larger practice was last month.
Okay.
But thank you for recognizing that. And then within that 189 providers, we have 24 oral surgeons at 23 locations. As of January 2nd, we received 59,826 claims, and we are up to 18,568 unique members served since implementation. So we had a little tiny bit of a dip in December, which is typical between the holidays and then if you do get some weather. However, what I will say is that when it comes to the mobile services, those wait lists are critical because they're able to move people into cancellations. And so we didn't have as much of a dip there as we did in, other places. You will be getting a copy of this handout. We've got a very robust schedule of mobile services now charted out until March. That's not the way it's necessarily going to stay because we are working with other organizations and individuals to schedule more events in different locations. All of the locations, as of Friday, had some openings available. The wait lists are always there. The exception is the visit to Spalding Academy, which is limited to those individuals who are there. But all the other events do have appointments available and the ability to go on a wait list. So we've had 135 mobile events since we started those up. 1,368 members have been treated in those clinics. And so, obviously we see this as a continuing part of our necessary provider network until, we have our other providers in those areas.
For access, Saturday and Sunday appointments for dentists.
Right. People are really, really happy with that. So, can you make my dentist do that? I can't even go on a Friday.
That was my point.
And that is why, we have our quarterly mobile strategy meeting coming up because we recognize that we're no longer, looking at short-term things. We're really now focusing on the moderate and long-term, planning for mobile services. You will also receive, along with a copy of this update, another copy of the member advisory board meeting, which is happening on the 23rd. And please, again, if you can continue to share that information, we want to have a really robust turnout for that meeting. People do have to register in advance, and there's instructions on the flyer about how they can go about doing that. As I sort of mentioned before and have in the past, we have ongoing meetings and the list is not limited to what I'm about to tell you, but mobile services strategy, special needs networking strategy. We have a dental director clinical meeting, which is between myself and the DentaQuest and Delta dental directors. We are still in attendance with Able New Hampshire for their oral health task force meetings, and we're working very closely with them to develop some materials that will help to support providers who are willing to work with special needs individuals as sort of a specialty. So we're very, very busy and continue to be very busy. I think that, you know, as you've heard described with the CCBHCs, you know, you implement a program and everything is okay with that implementation, but then you need to start working out, you know, refine things and really move forward. And, you know, that's where we are with this program. So I'm happy to take questions. And then my final update is a personal one. I just want to let you know that I will be retiring from my position at the end of next month. I'm hoping to continue to work with the department on a part-time basis after that. It's been an absolute pleasure to work with all of you. Without all of you, none of this work really works. So thank you. And I also want to thank you for everything I've learned from all of you. I've learned a lot. You know, you'll continue to see me around. I'm not leaving the state of New Hampshire. I will still sit on the Dental Society Foundation, as well as a private dentist on the Oral Health Coalition. Mike?
I just wanted to commend and thank Dr. Finney for all she's done for New Hampshire and the dental community and our patients. She has been just an amazing advocate and a champion for patients as well as dentists for the last 10 years and far beyond as a dentist. So thank you so much for your leadership, Dr. Finney, and we're not going to get rid of you just yet. So thank you.
Thank you, Mike. Brooke?
I too echo that. This is Joan representing the Hygienists Association. Thank you very much, Sarah.
Yeah, I mean, I know everyone on this call wants to echo what's been said already, but
Yeah.
it can't be said
I would
enough.
just-
Sarah, thank you so much for your commitment to this, and your vision for this dental program goes, I can remember the early days of it in different roles. So thank you so very much.
Thank you. Amazing.
So it's interesting managing the clock here. I think in terms of those things where we have something to say that's substantive. So in terms of the adult and youth reentry programs, we got our clearance. Though we had the waiver, we had to get approval on the implementation plan to begin working with Department of Corrections and SYSC and the rollout of those programs that became effective January 1st as planned. We're still in the process of 45 days or 30 days prior to release. So we're still in that period of where people aren't in that section yet. So it's sort of a soft start while we're waiting for the clock to move and working on refining things all the time. We have a twice weekly sort of a session at noontime to do any troubleshooting that needs to happen. So I've got to jump for noon for that. In terms of HCBS, I think that's something we can pick up next month. In terms of the different waiver programs, again, I think those are some things that we could talk to next month. I think they're under the Medicaid to Schools RFP.
I'm so sorry.
That RFP was issued. We've got responses. There's not much we can say at this moment. Time on that. And then I think that I missed the managed care contract. But I think we talked about CCBHCs. Another component that was built into that contract was the peer support under the CNHCs, right? And the element for paying for the services related to the community and youth reentries situation. We have a grant that we applied for I think $2.5 million worth of $5 million worth of funding to support over 4 years to support the rollout of the program. So we're hoping if we do get that grant money, that we'll be able to we plan to get to all the counties. We have more money to do that. We'll be able to go a bit faster, do more. Anything else in the contract was basically takes us through June 30th. We're already starting our work on our July 1st fiscal year plan. So I think if there are any other questions, I think that's a good way to make up some time on our agenda.
Yeah, absolutely. I had one question that I've been getting sort of in my travels, and that's to solicit from you all, what are any areas, if any, that you think are vulnerable to budget cuts either at the state or the federal level? The messaging, has been austere, but I wonder if that's sort of an effort to manage expectations versus a true blue effort to make drastic cuts.
I think the way I would respond to that, it's like every week or so there's a new thing, but there's Georgetown did a paper, and Kaiser did one today on like potential cuts that could affect the Medicaid program or ACA coverage. The interesting thing is like there's a menu of things that are would be pretty devastating to the Medicaid program overall. What actually they can get agreement on, I think that's probably the bigger picture. A lot of people didn't like Obamacare. 10 years, 10 tries. That's the program is different. Not saying that what would be things, but I do think that we could share a couple links with you to give you some sense of what's on the table. But I think the legislative process, it's easy to say we can cut this. Then when you actually start to look who's affected by it, but I think it's there's going to be can't just be passive about it. You're an advocate. You need to be engaged, and I think there were some positive things in the recently that came out in New Hampshire in the Senate. Republican position, they cited granted advantage among their high priorities in terms of sustaining, and the governor in her speech talked about the importance of behavioral health and access to both mental health and substance use disorder. What that actually looks like in terms of policies, we'll see. But I do think that with all the work that people have done over the years, we've made the impression that the head is connected to the rest of the body, and that healthcare coverage for the Medicaid expansion is beneficial to the entire healthcare market in terms of the cost of healthcare. We now have consecutively been either the lowest or the second lowest ACA premiums, and part of that is because we have risk pools that make sense in terms of where people are covered. So, I think that and our own budget challenges as a state in terms of where revenues are, I expect that this will be more challenging budget.
Well, we look forward to ongoing updates as the session moves on.
So I think we have a ways to go on the federal side.
Yeah. Oh, I know Henry's short on time, and Kelly's reminding me that Kara or somebody might have had a comment on the 805 subcommittee.
I didn't see her on.
Okay. Oh,
Hi, this is Nicole Bondet from Crotched Mountain. I work with Kara. They are still waiting for response from Brian till they move forward.
Okay, super good to know. Thank you.
Thank you.
All right. Well, we are past time, depending on which clock you look at. Thank you, everybody, for your patience and your indulgence. Can I have a motion to adjourn?
So moved.
Thank you. Second.
Second.
Thank you. All in favor?
Aye.
Hi.
Aye.
Everybody's gone.
Thank you, everybody.
Thanks. No, you snuck in the middle of the meeting. We couldn't be like asking all the questions. Are you